Get started. My name is Jessie Briscoe. I'm one of the PGY1 pharmacy residents here at Erlanger, and today I'll be presenting on alcohol withdrawal syndrome. Before we get started, I wanted to let you know that I have nothing to disclose. In terms of objectives, I hope that by the end of this presentation, you're able to identify risk factors for developing alcohol withdrawal syndrome, describe the mechanism of action of alcohol and the pathophysiology of alcohol withdrawal, and select an appropriate treatment regimen for alcohol withdrawal syndrome. Before we get started on alcohol withdrawal syndrome, though, I did want to just briefly review alcohol use disorder. This is a condition that affects 5.6% of adults and 1.7% of adolescents ages 12 through 17. So that's not an insignificant portion of our population, and it's certainly not an insignificant part of the population that we treat here at this hospital. In terms of diagnosis, alcohol use disorder is diagnosed using the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM-5. It's classified from mild to moderate to severe based on the number of symptoms that someone has. So this is assessed using a questionnaire that's beyond the scope of this presentation, but patients are assessed based on the frequency of their drinking, if it impacts their daily life or their ability to work, or if they do things that they don't remember or regret while they're drinking, or if they have withdrawal symptoms when they stop drinking. So now that we've discussed that, we can move on to the primary portion of this presentation, which is alcohol withdrawal syndrome. Before we go any further, I want you to test your knowledge. Our first question is, which of the following describes alcohol's mechanism of action? Is it A, an NMDA receptor agonist? B, does it decrease glutamate production? C, is it a GABA agonist? Or D, does it upregulate GABA receptors? Does anybody have any idea? Anybody? Okay, so it's actually C, it's a GABA agonist. So to go in a little bit further on alcohol's mechanism of action, it functions as a central nervous system depressant that works by facilitating GABA, which is the main inhibitory neurotransmitter in the central nervous system. It also works as an NMDA glutamate receptor antagonist, and that's the major excitatory neurotransmitter in the central nervous system. So by facilitating the inhibition of the central nervous system and decreasing the excitation, it exerts its effect as a central nervous system depressant. In terms of the pathophysiology of alcohol withdrawal syndrome itself, it's mainly based on the chronicity of someone's alcohol intake. So we'll walk through this graphic and see how things change as someone starts drinking more frequently. We'll start with someone who's a non-alcoholic, and as you can see, their GABA, their inhibitory neurotransmitter, is completely balanced with their glutamate, which is the excitatory neurotransmitter, resulting in a state of homeostasis. Moving on to someone who is an occasional user of alcohol, you can see that alcohol is stimulating the inhibitory effects of GABA, while glutamate remains the same or potentially decreased, which results in a net inhibitory effect. So that's why we see people who get that euphoric sense when they drink alcohol occasionally, sometimes might feel sleepy or more relaxed. As someone starts to drink alcohol more regularly, their body starts to compensate for that increased inhibition that's caused by alcohol stimulation of GABA. So the body compensates by upregulating glutamate in order to create a balanced state despite the alcohol intake. When someone suddenly stops drinking alcohol, you can see that GABA is no longer stimulated, but the glutamate remains upregulated, which results in a net excitatory effect, which is when we start to see the symptoms of alcohol withdrawal syndrome. Withdrawal symptoms can be classified in mild or moderate to severe categories, with mild symptoms being tremor, tachycardia, dilated pupils, nausea, vomiting, and hypertension, just to name a few, and moderate to severe symptoms being hallucinations, seizures, and delirium tremens. Symptoms can be further classified into different categories, with the first being autonomic hyperactivity. Most of those were encompassed by the mild symptoms that we just discussed, and they typically begin within 6 hours after someone's last drink and peak within 24 to 48 hours after their last drink. The next category is neuronal excitation, which is characterized by seizures. If someone starts experiencing seizures, they have a high risk of progression to delirium tremens. Typically, this neuronal excitation begins to occur within 6 to 48 hours after someone's last drink. Finally, we have delirium tremens. These are characterized by auditory and visual hallucinations, confusion and disorientation, clouding of consciousness, and impaired attention. Typically, these start within 48 to 72 hours of someone's last drink and may last for up to 2 weeks. Of note, delirium tremens are very dangerous and have a significant mortality rate of about 5 to 25%. So if we can prevent the progression to delirium tremens or DTs, that's very good for our patients. We'll move on to another test your knowledge question. This one is, which of the following is a reliable predictor of severe alcohol withdrawal? Is it A, average daily drinks consumed, B, medical or surgical illness, C, duration of alcohol use, or D, all of the above? Does anyone have any ideas? Okay, so this is a little bit of a trick question, and the answer is actually B, medical and surgical illness. So we'll discuss this a little bit more. There are certain predictors that are consistently predictive of severe alcohol withdrawal. So these are older age, medical and surgical illness, hyponatremia and hypokalemia, dehydration, a history of DTs or withdrawal seizures, thrombocytopenia, structural brain lesions, and elevated liver enzymes. Things that are not consistently predictive are the ones that we often think about in terms of someone having alcohol withdrawal, and those are average daily drinks consumed and duration of alcohol use. There's actually a scale that we can utilize to assess someone's likelihood of withdrawal that's known as the Prediction of Alcohol Withdrawal Severity Scale, also known as PAWS. So this scale first uses a threshold criteria that a practitioner could utilize to assess if someone is at risk at all of withdrawing. And this would assess their alcohol consumption within the last 30 days, or if they have a positive blood alcohol level on admission. So if the answer was yes to either of these questions, you would continue this assessment to determine how likely someone is to withdraw. That would take you to part B, which is the patient interview, and that assesses a number of the predictors that we previously discussed, like previous episodes of alcohol withdrawal seizures, delirium tremens, and combination of alcohol with other substances, along with blackouts, alcohol rehabilitation treatment therapy, or a combination of alcohol with other downers within the last 90 days. After you discuss that with the patient, you would assess clinical evidence, which would include a blood alcohol level on presentation of greater than 200, and the potential for increased autonomic hyperactivity. So that would be things like a heart rate of at least 120 beats per minute, tremor, sweating, agitation, and nausea. So all of these different criteria are scored, and a patient who has a score greater than or equal to 4 would indicate high risk for moderate to severe alcohol withdrawal syndrome. At this point, if you had a patient who did have a score of at least 4, you would move on to assessing their withdrawal symptoms. So that's when we get to the CIWA protocol, or the Clinical Institute Withdrawal Assessment for Alcohol Revised Scale, which I'll refer to as CIWA from this point forward. So this scale assesses how much someone is actually withdrawing. So it looks at things like nausea and vomiting, tremor, sweats, anxiety, headache, agitation, tactile, auditory, and visual disturbances, and then orientation and clouding of sensorium. I did want to particularly highlight that a number of the criteria that CIWA assesses require the patient to be able to communicate these things to you. So if someone can't communicate at all, there's no way for you to convincingly know if they're having auditory or visual disturbances or if they've got a headache. So CIWA is most appropriately used in patients who do have the ability to communicate with us. CIWA is also scored, and the score indicates someone's level of withdrawal. So absent to minimal withdrawal would be a score of 0 to 9, mild to moderate would be a score of 10 to 19, and then severe would be a score of at least 20. I wanted to note that CIWA, when it was originally underwent validation studies, patients were excluded from those validation studies if they were critically ill, post-surgical, admitted to the ICU, or if they suffered from complex comorbid illnesses. So that's a lot of patients that were eliminated from these validation studies. While it's not necessarily inappropriate to utilize CIWA in these populations, since it is a large portion of our patient populations, I do think it's important to note that and use it with a grain of salt. I also wanted to note that CIWA is not always used appropriately. There was a study that assessed the appropriate use of CIWA in a certain patient population that found that over 50% of patients that were on CIWA had 0 to 1 risk factors as assessed by the PAUSE criteria that predict someone's likelihood of withdrawal. But over 40% of those patients received benzodiazepines. So this study indicated that sometimes we're overutilizing CIWA protocols for patients who are not necessarily at risk of withdrawing. And despite their lack of risk for withdrawing, a number of those patients are getting benzodiazepines that may or may not be necessary. So now that we've discussed all of that, we'll move on to withdrawal treatment regimens, starting with ethanol. So we've already discussed ethanol or alcohol's mechanism of action, but ethanol can be administered in the hospital either enterally or IV. Previous studies that have assessed its use have been small and not powered, have used variable methods, and have found conflicting results. Ethanol is not addressed by current guidelines, so I thought it might be interesting for us to assess its benefits and concerns. So you can see that in general, the concerns for ethanol significantly outweigh its potential benefits. Some of the concerns are its inconsistent kinetics, its narrow therapeutic window, it decreases the seizure threshold, can contribute to hepatic failure, create toxic metabolites, cause sedation and respiratory depression, and it also has a number of drug-drug interactions. In terms of benefits, there's one proposed benefit for patients who are experiencing alcohol withdrawal, and that is that ethanol might have decreased sedation when compared to benzodiazepines, which are our standard of care. There was a study that was published in the Journal of Trauma in 2008 by Weinberg and colleagues that looked at IV ethanol versus diazepam for alcohol withdrawal prophylaxis in trauma ICU patients. So this assessed trauma ICU patients who had a history of chronic alcohol consumption of at least 5 drinks per day and looked at either IV ethanol that was titrated to maintain a Riker scale of 4 or diazepam 5 milligrams every 6 hours as needed to maintain a Riker score of 4. Their main comparison was the Riker sedation agitation scale, which is similar to the RASS scale that we would utilize at this hospital. In total, 50 patients were included. Of note, the ethanol group showed an increased deviation from a Riker score of 4 when compared to the diazepam group, and both groups trended towards under sedation. One patient in the ethanol group failed IV therapy versus 0 in the benzodiazepine group. IV ethanol offered no advantage over diazepam in terms of sedation or adverse events. So if we go back to our benefits and concerns, this study really disproved the only benefit that ethanol has. And so for that reason, it's not recommended for routine use in any patients who are experiencing alcohol withdrawal syndrome. So now we'll move on to the therapies that we actually do recommend. And we'll start with the clinical practice guideline on alcohol withdrawal management that's published by the American Society of Addiction Medicine. This was published in 2020. We'll start with our agents that can be utilized as monotherapy, starting with benzodiazepines. Benzodiazepines, mechanism of action is that they bind to GABA A receptors and enhance the GABA-induced inhibition of the central nervous system, which, as you remember, is very similar to how alcohol itself works. Adverse effects of benzodiazepines are oversedation, respiratory depression, encephalopathy, and agitation. There are a number of benzodiazepines that we can utilize for alcohol withdrawal syndrome. I've highlighted some of those here. You can see that they vary in terms of their half-lives, their onset of action, and their routes of administration. I did specifically want to highlight the ones that have hepatic metabolisms because we are utilizing these in patients who have a history of significant alcohol use and therefore might be predisposed to having liver dysfunction at baseline. So the two on this chart that do have hepatic metabolism are our long-acting agents, diazepam and chlordiazepoxide. So that's just something to take into account when you're choosing what agent you should use in your specific patient. I did also want to note that despite their hepatic metabolism, the guidelines do prefer long-acting agents in general over short-acting agents. But once again, it's best to take into account your patient-specific considerations before choosing what agent to use. So we'll talk first about symptom-triggered treatment with benzodiazepines. There are a number of different methods that you can utilize for alcohol withdrawal syndrome with benzodiazepines, but symptom-triggered treatment is probably our most utilized. So this would be benzodiazepine dosing that's based on someone's CIWA scores. So if their scores are lower, they will get less milligrams of a benzodiazepine and be assessed less frequently. And if their scores are higher, they will get more benzodiazepine and be assessed more frequently. This regimen is not recommended for use in patients who are unable to communicate because, as we discussed earlier, CIWA requires patients to be able to communicate what's going on so that they can properly be assessed. It's also not recommended for patients with a history of alcohol withdrawal seizures. Besides these two populations, the guidelines do recommend it as their first-line preferred therapy. Next, we'll talk about fixed dose regimens. So this would be when a benzodiazepine is administered in divided doses based on a fixed daily dose. That fixed daily dose would be calculated based on their total daily alcohol consumed or their CIWA scores. Once someone is stable on a fixed dose regimen, at that point, you could begin to taper them. The guidelines recommend fixed dose regimens in patient populations where symptom-triggered therapy is not recommended. So again, that would be our patients who are unable to communicate or who have a history of alcohol withdrawal seizures. Because fixed dose regimens can be calculated based on someone's amount of alcohol consumed, I thought it might be prevalent to show you what one drink of alcohol technically looks like. So that one drink is equivalent to 10 grams of ethanol, which would be one small glass of wine, one 12-ounce can or bottle of beer, one cocktail with only one shot of liquor in it, or just one straight 30 milliliter shot of liquor. So when we're talking to our patients about how much they're drinking, it's important to note what their version of a drink might be versus what the technical version might be when we're assessing what type of protocol they should be put on. Below, I have listed an example diazepam taper for you. So you can see that the taper is based on someone's CIWA scores. And we taper the total daily dose by 25 to 50% daily over a course of 3 to 5 days, with a longer taper as needed if someone's CIWA scores are higher. And you can either choose to taper based on someone's milligrams per day or their dosing interval. Okay, so we'll talk about this study that was published in 2014 in Alcohol and Alcoholism that compared fixed tapering dose regimens versus symptom-triggered regimens of lorazepam for alcohol detoxification. So this study looked at male patients who were admitted for uncomplicated alcohol withdrawal, and it compared fixed tapering dose regimens as determined by CIWA score versus symptom-triggered therapy based on CIWA scores. So they compared the total amount and duration of lorazepam therapy along with adverse events and complications. In total, 67 patients were included, and they found that less lorazepam was utilized in the symptom-triggered group and that the symptom-triggered group had a shorter length of therapy with no difference between the groups in seizures or delirium tremens. So in a patient population where utilizing symptom-triggered therapy is appropriate, utilizing that instead of fixed dose regimens can result in shorter therapy and less benzodiazepine administered, which is why the guidelines recommend symptom-triggered therapy as our primary method of treatment in patients who this is appropriate for. And then the last type of benzodiazepine regimen that we'll discuss is a front-loading regimen. So this would be utilized for our patients who are at severe risk of withdrawal, who have acute medical illness or a history of withdrawals. So these would be the patients that would be most concerned about progressing to something like DTs. The front-loading regimen may be based on CIWA scores or a fixed schedule, but essentially you give the patient a significant amount of benzodiazepines on the front end to prevent the withdrawal from occurring and prevent progression to seizures and delirium tremens. Typically, this front-loading regimen is followed by a long-acting benzodiazepine taper, like the ones that we've already discussed. And the guidelines recommend this for use in patients whose CIWA score is greater than or equal to 19. And if you remember back to the beginning, those are our patients that are showing signs of severe withdrawal. So now we'll discuss this study that was published in Clinical Toxicology in 2019 that looked at the effect of early and focused benzodiazepine therapy on length of stay in severe alcohol withdrawal syndrome. So this population is a little bit different than the one that we previously discussed. It looked at patients who were requiring diazepam doses greater than 30 milligrams. So those patients who were experiencing symptoms of severe withdrawal. It assessed a pre-group that utilized symptom-triggered doses of diazepam and phenobarbital based on RASS versus a post-group that looked at escalating doses of benzodiazepines or phenobarbital for 24 hours, and then utilized a taper over 72 hours to get the patients off of that fixed dose. They compared hospital length of stay, ICU length of stay, benzodiazepine requirement, and ventilator-free days, and included 113 patients. They found that the post group had shorter hospital and ICU length of stays, but there was no difference in the rate of intubation, duration of ventilation, or ventilator-free days. So this study showed us that if we utilized front-loading dose regimens in these patients who are at risk of severe withdrawal, we can potentially decrease their length of hospital and ICU length of stay, which would be beneficial. So since we've talked a lot about benzos, I wanted to do a quick review on what the guidelines say. The guidelines prefer symptom-triggered therapy in patient populations that it's appropriate for. They prefer long-acting benzodiazepines. Of note, though, we want to make sure that those are appropriate for our specific patients. They recommend a fixed dose with a taper if symptom-triggered therapy is contraindicated. And again, that would be our patients who can't communicate or who have a history of alcohol withdrawal seizures. And they recommend a front-loading regimen if someone is showing signs of severe alcohol withdrawal with CIWA scores greater than 19. So now that we've talked about benzos, we can move on to our other monotherapy agent, which is phenobarbital. This works as a long-acting barbiturate that stimulates GABA, once again being very similar to the mechanism of action of alcohol itself by stimulating GABA. And it's dosed at 260 milligrams IV once, followed by 130 milligrams IV every 30 minutes as needed. I did want to highlight that this dose is significantly lower than what we would use for someone who is actively seizing. That dose is closer to 15 mg per kg, which would be close to like a gram or a gram and a half, depending on the size of the person. So when providers are sometimes concerned about using phenobarbital, that might be a good reminder. Adverse effects of phenobarbital are sedation, respiratory depression, and hypotension. And because of that, it should only be utilized in highly supervised settings like an intensive care unit. Guidelines recommend this as appropriate monotherapy for patients at all levels of withdrawal. There was a study that was published in Curious that looked at phenobarbital versus lorazepam for management of alcohol withdrawal syndrome. It assessed patients who were admitted to a general medical ward who are experiencing alcohol withdrawal syndrome or alcohol intoxication and compared phenobarbital or lorazepam. It assessed their hospital length of stay, their ICU transfer rate, and their 30-day readmission rate. In total, 669 patients were included. And this study found that phenobarbital was associated with a shorter hospital length of stay, fewer 30-day hospital readmissions, and fewer 30-day emergency room visits after discharge. But there was no difference in alcohol-related 30-day readmissions or ICU transfer rate. So this study shows us that utilizing phenobarbital in comparison to benzodiazepines is a reasonable option, and we could utilize it in our patient population if we thought it was appropriate. So just to review one more time what the guidelines say, phenobarbital is appropriate monotherapy that can be utilized in all levels of withdrawal, but it should only be utilized in highly supervised settings due to its likelihood of causing oversedation and respiratory depression. So now that we've talked about our monotherapies, we're going to move on to adjunctive therapies. We'll start with gabapentin. So gabapentin works because it's structurally related to GABA. It's dosed at 400 milligrams every 6 to 8 hours. And adverse effects of gabapentin include respiratory depression and sedation. The guidelines actually say that gabapentin can be used as monotherapy for mild to moderate withdrawal, but for severe withdrawal, it should be utilized only in adjunct to other therapies. There was a study published in Pharmacotherapy in 2019 that looked at high-dose gabapentin for the treatment of severe alcohol withdrawal syndrome. This study assessed patients who were admitted to the emergency room with a diagnosis of severe alcohol withdrawal syndrome, and they received either high-dose gabapentin, and that was defined as at least 1,800 milligrams in 48 hours, or no gabapentin. They compared benzodiazepine requirement in terms along with CIWA scores, RASS scores, and hospital length of stay. The gabapentin group was associated with less lorazepam requirement, lower mean CIWA scores and maximum CIWA scores, and a shorter hospital length of stay. The two groups had similar RASS scores of note. So this shows that utilizing gabapentin in our patients who are experiencing withdrawal could reduce the amount of benzodiazepine required and potentially reduce the risk of progression of their alcohol withdrawal syndrome. So now we'll move on to valproic acid. This works by mimicking GABA's action at the postsynaptic receptor sites, and it's dosed at 300 to 500 milligrams every 6 to 8 hours. Adverse effects of valproic acid include GI distress, tremor, sedation, hepatotoxicity, and elevated ammonia, and the guidelines recommend it only as an adjunct to benzodiazepines. There was a study that was published in Alcoholism, Clinical and Experimental Research in 2001 that assessed divalproic sodium in alcohol withdrawal. So this study looked at patients who were hospitalized with CIWA scores of at least 10, and they looked at divalproic sodium 500 milligrams 3 times daily versus standard CIWA symptom-triggered protocols. They compared oxazepam requirements along with CIWA scores, physiological distress, and side effects, and in total included 36 patients, and found that divalproic sodium was associated with less oxazepam and less progression in withdrawal symptoms as judged by CIWA scores. There was no difference in tolerability between groups. So once again, divalproics could be utilized similarly to how gabapentin could be utilized in adjunct to our benzodiazepine therapies to potentially reduce the amount of benzodiazepine required and reduce the progression of alcohol withdrawal symptoms as well. So finally, we'll move on to adjunct therapy in critical care populations, starting with propofol. So propofol is a short-acting lipophilic intravenous general anesthetic that works as a GABA-A agonist. Adverse effects of propofol are significant for respiratory depression, sedation, bradycardia, hypotension, hypertriglyceridemia, and propofol-related infusion syndrome. The guidelines recommend this as a useful adjunctive therapy in patients who are already requiring mechanical ventilation. There was a study published in the Annals of Pharmacotherapy in 2014 that looked at propofol-containing regimens versus benzodiazepine regimens for alcohol withdrawal patients who are requiring mechanical ventilation. This study was done in mechanically ventilated patients who were experiencing alcohol withdrawal syndrome symptoms. They compared propofol-containing infusions versus benzodiazepine infusion monotherapy, and looked at time to resolution of alcohol withdrawal symptoms, along with hospital and ICU length of stays, days of mechanical ventilation, reintubation rate, mortality, and side effects. This study included 64 patients and found that the propofol group required fewer benzodiazepine boluses, which would indicate that these patients were experiencing less severe symptoms of withdrawal, which is why they didn't receive as many boluses. There was no difference between the groups in terms of time to resolution of alcohol withdrawal symptoms, or hospital or ICU length of stay, or days of mechanical ventilation. So propofol could be a potentially beneficial agent for our patients who are requiring sedation and are mechanically ventilated in the ICU experiencing symptoms of alcohol withdrawal. Next, we'll talk about dexmedetomidine. This is an IV central acting alpha-2 adrenergic agonist. Adverse effects of it include hypotension and bradycardia, and guidelines recommend it as adjunctive therapy to benzodiazepines to control autonomic hyperactivity and anxiety that's associated with alcohol withdrawal syndrome. This study was published that assessed the treatment of alcohol withdrawal syndrome with and without dexmedetomidine. It looked at medical ICU patients who were experiencing severe alcohol withdrawal and looked at patients prior to and after initiating dexmedetomidine. They compared the patients 24 hours before and after its initiation and looked at it in terms of lorazepam equivalents and CIWA scores. This study included 77 patients and found that dexmedetomidine was associated with decreased lorazepam requirement, reduction in CIWA scores, longer hospitalizations, hypotension, and bradycardia. So while this agent could be useful in terms of preventing and slowing our progression of alcohol withdrawal syndrome, it definitely doesn't come without its side effects that we should take into account when we're determining if it would be useful in a specific patient. And then the last drug that we'll talk about today is ketamine. So ketamine works a little bit differently than all the other drugs that we've talked about. Most of the other ones that we've discussed work on GABA and the inhibitory side of the pathway, but ketamine is an NMDA antagonist. So if you remember from the beginning of the presentation, this would work on the excitatory side of the neurotransmitter pathway in the central nervous system. So ketamine has adverse effects that include hallucinations, delirium, and bradycardia, and guidelines recommend it as potentially beneficial adjunctive therapy. Of note, they put that word potentially in there because ketamine hasn't been studied quite as much as some of our other agents that we've discussed. So there is room for us to learn more about its potential use in alcohol withdrawal syndrome. There was a study again published in the Annals of Pharmacotherapy, this one in 2015, that evaluated ketamine adjunctive therapy to benzodiazepines for management of alcohol withdrawal syndrome. And this looked at ketamine administration for the management of alcohol withdrawal syndrome and assessed both pre and post ketamine initiation and compared diazepam equivalent requirements, sedation, alcohol withdrawal scores, and ultimately included 23 patients. The mean infusion rate of ketamine was 0.21 milligrams per kilogram per hour. And following ketamine initiation at 6 hours, there was no change in sedation or alcohol withdrawal scores, but we did start to see some changes as the timeline progressed. So at 12 hours, the ketamine group required 40 milligrams fewer diazepam equivalents, and at 24 hours, 13.3 fewer milligrams of diazepam equivalents. So that's something to take into account if you think that ketamine could be a beneficial agent in your patient, that it could potentially reduce their total benzodiazepine requirement. All right, we're to another test your knowledge question. So this question is, which of the following are appropriate adjuncts to benzodiazepines for alcohol withdrawal syndrome? Is it A, gabapentin, B, valproic acid, C, ketamine, or D, all of the above? This one was easier than the others. It's D. So all of the above can be used as potentially appropriate adjunct therapies to benzodiazepines for alcohol withdrawal. All right, so now that we've talked about all the agents that we can utilize for alcohol withdrawal syndrome, I thought it was pertinent for us to discuss Erlanger's protocol. So Erlanger actually has two different protocols for alcohol withdrawal syndrome. One is targeted for patients on the floor versus the other that's targeted for patients who are in the critical care unit. So we'll start with the floor protocol. So this protocol is a symptom-triggered treatment protocol that utilizes CIWA. And so you can see, as we were talking about earlier, that if someone has lower CIWA scores, they would get less benzodiazepine, be assessed less frequently, versus if they had higher scores, they would get more milligrams of benzodiazepine and be assessed more frequently. The protocol indicates that a nurse should notify a physician if CIWA scores become greater than 20. So that would be a sign that a patient is experiencing severe withdrawal. If a patient requires greater than 12 milligrams of lorazepam in 24 hours, because at that point we would start to worry about their respiratory status and their level of withdrawal. And then also if CIWA increases by greater than 5 in 1 hour. Moving on to the ICU protocol, you can see that the top portion is similar in terms of symptom-triggered therapy, though patients are assessed more frequently in the ICU than they would be on the floor with the same CIWA scores. And then there's a separate section of this protocol that utilizes some of our adjunctive agents. So if a patient receives at least 8 milligrams of lorazepam in 2 hours, they could be started on phenobarbital, loaded at 260 milligrams IV once. And then the maintenance dose in the protocol is a little bit different than what the guidelines recommend at 130 milligrams IV every 2 hours as needed versus the guideline recommendation for every 30 minutes as needed. So that's something to take into account as well. That the as needed is based on provider discretion, but can be based on CIWA or RAS scores. Another adjunctive therapy is dexmedetomidine, and this would be titrated to target a RAS of -2 to 0. Finally, if a patient is intubated and their CIWA scores are greater than 20, we could utilize midazolam. So this would be a midazolam drip that would be titrated based on RAS scores. I did want to particularly highlight that for patients who are on a benzodiazepine drip, we utilize midazolam in place of lorazepam because lorazepam includes propylene glycol, which can accumulate and cause lactic acidosis and renal failure. So that's why we utilize midazolam. So now that we've discussed all of Erlanger's protocols and all of the treatment regimens, I thought I would give you my recommendations. So I would recommend the addition of a pause assessment prior to the initiation of CIWA protocol. So this would assess patients' risk of withdrawal before we put them on a protocol that could potentially give them benzodiazepines that they may or may not need. In addition, I would recommend an alternate protocol for patients who are unable to communicate or those who have a history of withdrawal. So that would be something like a fixed dose benzodiazepine taper that would be more appropriate in this patient population. Finally, I would recommend the utilization of guideline recommended adjunctive therapy when needed. As we discussed, there are a number of agents that could be utilized for our patients who are experiencing alcohol withdrawal on the floor and in the ICUs, and there are only a couple mentioned in the ICU CIWA protocol, and there are none that are available in our protocol on the floor. So I think we have some room for improvement there as well. That concludes my presentation on alcohol withdrawal syndrome. What questions do you guys have? Britt?
I have a question about the way we currently assess risk of withdrawal, like on patient who's taking state emergency department.
Yeah.
Why do you think we inquire about the history or quantity of alcohol consumed as our approach to ordering CIWA protocol? I think that's a really big point of like misunderstanding. Because I frequently see our providers document how many drinks per day over a given period of time, but I noticed that neither one of those assessments were mentioned as potential risk factors for withdrawal.
Yeah, so Britt's question is why we typically document patients and their recent history of alcohol intake, the number of drinks that they drink a day, and for how long they've been drinking as a reason to start CIWA protocol in the hospital. I'm not sure about that. If it's just something that's been passed down from physicians over time, that's how we should be assessing patients, but none of the literature indicates that that would be an appropriate way to assess someone's risk of withdrawal. So I think that there is some room for education, potentially verbally with our physicians and mid-level practitioners, in addition to potentially adding something into our protocol that notes what is predictive and is not predictive of someone's level of withdrawal. Okay, Britt.
Do you think that there's a role for oral phenobarbital for patients, or any difference in the incidence of sedation and respiratory depression, or should that be reserved as IV therapy only for patients who may be like in an ICU or?
Yeah, so Britt's question was if we could utilize oral phenobarbital on the floor for patients who are experiencing alcohol withdrawal syndrome. That's something that I didn't look too much into, but I definitely can look into it and let you know if it seems like it would be a reasonable option or if we would still be significantly concerned about the respiratory depression associated with phenobarbital use. I do know that sometimes it is utilized outpatient kind of in place of like a long-acting benzodiazepine taper for patients. But I'm not sure how much we do that here or what the specific risks would be with that dose in that population.
Yeah, I see use of Precedex frequently. And
Yeah.
often at the expense of providing the needed benzodiazepine to manage the withdrawal.
Mm-hmm.
So we get into a situation where patients are becoming hypotensive and bradycardic because we're pushing doses of Precedex instead of giving, a GABA agonist. And so I wonder, we've not used oral phenobarbital in our patient population due to concerns about respiratory depression, but I just wondered if you've come across any algorithms that might suggest using that for like the patient you mentioned who has a history of withdrawal seizures or.
Yeah, that's the interesting thing about our utilization of Precedex is that Precedex can help with the symptoms of withdrawal, but it's not actually helping with the progression of the withdrawal syndrome. Whereas phenobarbital, if the side effect profile would be similar for our floor patient, actually would help with withdrawal itself and the progression of withdrawal. So that's definitely something that we could look into potentially utilizing more often, I think. Any other questions? No? Okay, we'll call it a day. Thank you, guys. Sorry, I forgot to put the credit up there. Here you go.